Our next speaker is Alex Reynolds. Alex started off her career at Princeton, and then she got her MD at Columbia. She did her residency at Columbia, where we began interacting first in neurology, and then her fellowship in neurocritical care at Columbia and Cornell. She is assistant professor of neurosurgery and neurology here at Mount Sinai. She's co-director of teleneurocritical care, director of the Neurocritical Care Fellowship, and her research focuses on subarachnoid hemorrhage, intracerebral hemorrhage, status epilepticus, neurotrauma, and the neurological prognostication of survivors of cardiac arrest and the neurological management of patients in fulminant hepatic failure. And today we're going to hear neurocritical care pearls in disorders of sodium from Alex. Thank you very much, Alex.
Thank you. Let me just make sure I'm sharing my screen. Okay. Today we're going to talk about hypo and hypernatremia. This is something that comes up really commonly, not only in the neuro ICU, but in neurosurgical patients. And I'm hoping by the end of this, you'll be able to manage this on your own. If you take nothing else from this talk today, what I want you to understand is that any disorder of sodium is actually a problem with water balance and not with sodium balance. And we're going to talk in a second about why, but hypo and hypernatremia have almost nothing to do with the patient's salt load. And this is why salt tabs are rarely the answer. So not to get too basic, but just remember that your levels of sodium and your the way that you stay eunatremic is thanks to 3 different hormones. Then this is the RAS system that you may remember from medical school. So angiotensin 2, aldosterone, and ADH or vasopressin are the 3 main hormones. And if you look at what they're doing, they almost all act on the ability to take water back into the body. Angiotensin 2 also helps by activating the hypothalamus, which increases your thirst and activates you to drink more. Aldosterone does help with a little bit of sodium reabsorption, but mostly it acts by retaining water and then helping to release antidiuretic hormone, which again will also keep your water in your system. So first, let's talk about hyponatremia. So we'll start with a case, and this is a case we had a couple years ago in the neuro ICU. 30-year-old woman went to EZoo, took ecstasy, and complained that she was feeling very thirsty. So she drank a ton of water overnight, became altered, and then was brought to the emergency room because she was only responding to pain. So on arrival to the emergency room, she has a normal blood pressure, normal heart rate. If anything, she's hypothermic. She's altered, moaning. Her pupils are large, dilated, and fixed. And she has increased tone in all 4. And her initial labs are notable for a sodium of 116. So before a workup is done in the emergency room, she gets 3% and then is intubated and sedated for a CAT scan. So the question is, how do we approach hyponatremia? So the first thing I kind of want to tell you guys is not to freak out, right? So you want to make sure that you repeat the BMP and make sure that it's an actual value before you start responding to it. We use a lot of things in the ICU that can cause pseudo-hyponatremia, meaning that the patient's sodium is not actually that low, but because of the way it's measured in the lab, it's going to look much lower. So mannitol, we're often freaking out and getting a BMP at the same time as we're giving mannitol, and so you're going to see pseudo-hyponatremia. Significant hyperglycemia can also cause that. And then in patients who are on high doses of Clevy or propofol, they're actually going to have very high lipids. And so their sodium can look relatively low because of that. You don't have to remember these formulas. We basically never use them either, but I just put them over there to show you that there is a way to calculate it if you're really wondering what the true sodium is, okay? So the first step is to repeat the BMP and try to assess what's going on with the patient. All right, and then the next step is to determine the volume status. And that's going to be true for hypernatremia and hyponatremia, because as I said, it's all about water, not about sodium, okay? So this can be the hardest thing to do, and you're going to try to assess the extracellular volume, right? So the intravascular volume. So, you know, we don't have to go through every single thing here. I just want to note that patients who are chronically hypervolemic from either renal failure because they can't get rid of water, or because of heart failure or cirrhosis where they don't have forward flow that's adequate to the kidney. So the kidney thinks the kidney thinks that the patient is intravascularly depleted because there's not enough forward flow and therefore retains water. Those patients are going to be hypervolemic and chronically hyponatremic. In those patients, it can be very dangerous to try to just reflexively increase their sodium with things like 3% because they're already hypervolemic. They usually don't have a tolerance for much more volume, especially the cirrhotics and the heart failure patients. And then you're going to try to throw 3% at them, which is just going to further overload them, okay? And that can cause cardiac issues and pulmonary issues. So unless there's a true emergency, we try not to actually change these patients' sodiums because this is where they live, okay? Patients who are euvolemic can be one of two things. They could have just drank a ton of water, right? I don't know if they do this anymore, but when I was a resident, they were always doing these like water chugging contests, and patients would come in with sodiums of like 110, having won the contest, but having been unresponsive. And so that acutely can change your water content, right? And then SIADH, which we see a lot in our neuro population, the patients are usually euvolemic. It's just that they're hanging on to too much body water. And then the hypovolemic patients are also seen a lot in our neuro population. It's the cerebral salt wasting, adrenal insufficiency, and then we can also have patients who are just very volume down from diarrhea or sweating, okay? So, you know, I am telling you about how to determine I'm telling you to determine the volume status because then we're going to send some labs to figure out what's going on. But that sounds kind of like easier said than done in some ways. So do any of the residents, can you guys think of ways that we can determine volume status?
We can look at the
Do an ultrasound.
Ultrasound. Okay, Abby. So I'm going to make you do the ultrasound. And what are you looking for?
Looking for so you can look at inferior vena cava.
Okay.
And yeah.
So the inferior vena cava collapsibility is something that is we think we use a lot.
Intra-abdominal pressure as the changes in the intra-abdominal pressure and I think the caliber.
Okay, yeah. So the caliber of the IVC is helpful in patients who are mechanically ventilated. It's not as helpful in patients who are not. But you can also just ultrasound the heart and take a look at how much volume is actually in the left ventricle. If the patient's very hypovolemic, you'll see the walls of the ventricle just kissing because there's nothing in the ventricle. Alex, you were about to say something?
I was going to talk about IVC contractility or compressibility.
Mm-hmm. Halima, do you have any thoughts?
We can start with just a physical exam and make sure, like, to see if there are any signs of volume depletion, like skin turgor, capillary recall. Look at the JVP.
Going back to basics, great. Ray?
Okay. I think Halima already mentioned about looking at the blood pressure and heart rate.
Good, blood pressure and heart rate, very, very basic, right? Like if someone's hypotensive and tachycardic, they're probably volume down. Good. I'll give you some other stuff. Serum labs, right? We used to talk a lot about the BUN to creatinine ratio, looking at a patient's urine. And then the easiest thing that we do a lot in the ICU is the passive leg raise. So if you think a patient might be hypovolemic, you raise both their legs up, and it's basically an auto transfusion, right? You're just giving them back the blood in their legs. And if their blood pressure goes up and their heart rate goes down, then that's your volume challenge that you've just done that's positive, and you can go ahead and give them more fluid, okay? There's a lot of different stuff that we use, ranging from very basic to more complicated things like stroke volume variation when we do more aggressive cardiac management. And then even basic things, like if someone comes in with a hematocrit of like 50 or 55, they're probably volume down, right? Because no one should have a hemoglobin or hematocrit that high. Okay, so there's a lot of different things that we can use. So then once you've figured it out and you think you know what's going on, you're usually also waiting for labs. So you can just start a treatment. So, you know, if you think the patient's hypovolemic, obviously you want to give them volume. We in the neuro ICU are always kind of thinking about cerebral salt wasting versus SIADH, right? And the reason that it's super important to distinguish those two is that their treatments are completely different. So if the patient has SIADH, you're going to restrict all free water. We usually don't even give them IV fluids, depending on what their serum osms are, because just giving NS, for example, can be relatively free water for them, depending on how concentrated they're making their urine. Cerebral salt wasting, on the other hand, you want to just keep up with volume. So you can do 1-to-1 urine output repletion. So obviously those two things are completely at odds with each other. And oftentimes if we're not completely sure, or it looks like a mixed picture, we'll check a sodium, we'll give 500 cc's or a liter of NS, and then we'll check another sodium. If the sodium's gone down, it's SIADH. If it's gone up, it's cerebral salt wasting. Obviously, you have to make sure that it's not dangerous hyponatremia when you're doing that, because you don't want to drop the sodium any lower, but we'll talk in a second about dangerous hyponatremia. If you think the patient has adrenal insufficiency, you can just trial hydrocortisone. And if the patient is volume overloaded, oftentimes they actually get better with just diuresis, okay? So then the question is, what kinds of fluids are you going to use? And is the patient symptomatic or asymptomatic? So it can be difficult in neuro to decide if a patient is symptomatic or asymptomatic, because oftentimes our patients are already altered and we don't know if their hyponatremia is contributing to their altered mental status, okay? But symptomatic can mean sleepy, it can mean severe headaches, it can mean seizures, and it can mean, you know, radiographic evidence of herniation, or clinical evidence of herniation, right? So it can be a little complicated. Our reflex is to want to make all the numbers look good, but like I said, there are patients who live at a sodium of 128 or 130 because they have chronic SIADH or they're on medications that cause hyponatremia at home. And so those patients, even if you want to try to fix the sodium, you don't have to try to fix it as quickly. So if a patient is symptomatic, you're almost always going to give hypertonic saline, okay? Like I said before, if the patient is volume overloaded, you want to be really careful about how much hypertonics you're giving, because you're going to volume overload them and potentially cause cardiovascular collapse. And if they're asymptomatic, you can just use NS or you can volume restrict, depending on the underlying problem. And then the most important part while you're correcting is to make sure that you're monitoring them and that you have a goal. So, you know, when I was an intern, everyone said no more than 12 milliequivalents in 24 hours. We now know that that's actually not correct, that even 12 milliequivalents per hour can cause central pontine myelinolysis in certain patient populations. So for example, someone who is a chronic liver cirrhotic, you can cause CPM just by increasing the sodium by 8 points in 24 hours. So we have to be really careful with certain populations. If it's chronic hyponatremia in a non-cirrhotic, we think that 8 milliequivalents per day is appropriate. If it's acute and symptomatic, you can correct it much faster. And we're going to go back to that first case where presumably this is a very acute cause of hyponatremia. And you can calculate the sodium deficit and then try to calculate it. But generally, I will say we don't actually do that. That's what the renal consult people do. So let's go back to this case then. So this is the 30-year-old woman who took ecstasy and drank a ton of water. So ecstasy can cause SIDH, and she also probably had some psychogenic polydipsia in addition. Her boyfriend said that she drank 5 liters of water overnight. And so we know that she was doing okay throughout the night and then became a little altered at 8 a.m. and she's presenting about an hour later. So she has the sodium of 116. This is her CAT scan. So I'll point out that she's got diffuse cerebral edema. She has no sulci at the top. This is a global process. She's starting to develop a little bit of pseudo subarach because of the global cerebral edema. And she definitely has some impending uncal herniation. And we know that her pupils are unreactive, right? Post the 3% that she got, her sodium comes back at 118, and her UTOX is positive for amphetamines and benzos. So let's see. Frank, what do you think her volume status is? I'll go back to her labs to help you out.
I think she's still hypervolemic.
She might be hypervolemic from all the water that she drank. She's certainly not hypovolemic. We can agree on that, right?
No, yeah.
Okay. Her urine osm came back at 127, which is probably euvolemia for her. And so then we're going to try a treatment and choose the fluid. So Travis, what is the first treatment you want to give her?
I would try normal saline.
Okay. I'm going to remind you of her exam, which is that her pupils are still unreactive. Do you want to change your answer?
Then I would do 23%.
Yeah. So, we told the ER we were going to do 23% and they freaked out saying, you can't change her sodium that fast. But she's hypertonic, she has urinary incontinence, and she has unreactive pupils. So at that point, it doesn't really matter. You're going to just give 23%. So we gave 23%, her sodium improved, and we monitored labs quite frequently. And I'm showing you her labs here, basically from 121 when she showed up to the NSICU, within about 24 hours, we corrected her from 121 to 140. Okay, so that's 19 points. Kurt, do you think that's too fast?
Not for an acute drop. I think we can correct it much faster.
Good.
In the chronic patients.
Yeah, I agree. And so she woke up the next day, got extubated, and signed herself out AMA within 10 hours. Okay. So this is just a reminder that it helps to have a history. And if you're not sure, it can get very complicated. But in this particular situation, within 24 hours, she went from 116 to 130 something, and she was fine, and hopefully doesn't do that again. All right, let's switch gears now to hypernatremia. So we'll start with a case of Dr. Kellner's. This was a 57-year-old guy with a history of diabetes. He had an ICH that was treated by scuba. He did have a residual seizure disorder and ultimately needed a PEG, but he was interactive at baseline and was sent to a nursing facility. And the nursing facility sent him back a couple of months later with 3 days of progressive mental status decline, increased work of breathing, and he actually required intubation at the nursing facility. So perhaps they needed to have called a little earlier. On arrival to the emergency room, he was hypotensive for him. He was tachycardic for him. He's tachypnic and he has a fever. And I think it was 2 months after his discharge, his weight, which let's be honest, he didn't have a weight in the emergency room, but when he came up to the ICU, we weighed him. And he was 12 kilos down from our last weight, okay, in 2 months. And he was unresponsive to pain, but had intact cranial nerves. His CAT scan was unremarkable. It was just the chronic changes from his ICH. His sodium was 160 with a glucose of over 1,000. And it looked like he was in DKA. He had a normal creatinine at baseline, but his BUN creatinine was elevated. And then as you can see here, his urinalysis was notable for glucosuria, and he had an elevated lactate. Okay. So how are we going to approach hypernatremia? So again, the first step is don't freak out, repeat the lab. Especially in the emergency room, they may have drawn the lab just proximal to an IV. And so if the patient's getting NS, they may be relatively hypernatremic, right? And then again, because all these sodium disorders are really water disorders, it's really important to figure out the volume status, okay? So again, if the patient's hypervolemic, that is probably because they've already been in an ICU for a really long time. So that is every hemicranie patient where we've bumped up the sodium. They're usually also hyperchloremic because we've just been giving a ton of sodium. So those patients are usually not going to be seen in the emergency room. That's like the sequelae of what we have done in the ICU. Euvolemic patients will be either early DI, or we've been diuresing them, and instead of giving them isolite, we've been giving them NS. And so they're just, they're going to be relatively salt loaded by us. And then the hypovolemic patients are patients who are excessively diuresed or are vomiting or have diarrhea, okay? So obviously step 3 is if the patient's severely hypovolemic, you're gonna correct that, right? Because again, you're treating whatever you can to prevent the patient from decompensating. And then once the patient turns into euvolemic, then you're going to try to replace the water deficit over 48 hours, unless the patient has been chronically hypernatremic for a long time. So in the patients who had, a malignant MCA, where we now have pushed up the sodium to 160 and they've stayed there for several days to weeks, those patients, we're not going to suddenly bring them down over 48 hours, right? So, this is what renal always comes by and tells us about is the free water deficit. And again, you don't need to remember these formulas. You just need to know that we can actually calculate that and then try to figure out how fast fluids need to go in order to correct the hypernatremia. Oftentimes in our patient populations, we don't want to correct the hypernatremia, right? We just want to let them kind of drift down with free water flushes as opposed to starting half NS or D5. If it's acute hypernatremia, you want to replace the water deficit very quickly. And if it's chronic, then you're just going to go a little slower. Just because a lot of our patients end up in DI, either because they have catastrophic brain injury from like a TBI, or because you guys have caused it by resecting a pituitary, for example. If the patient has DI, you can give all the free water you want, but you may not be able to actually keep up unless you give DDAVP. So in patients who are at risk for DI, you want to allow them to drink to thirst. The issue is if a patient is post-op and is poorly responsive and cannot drink, those are patients where you're going to need to be really careful about their fluids. So often what I'll do is replace their urine output hourly with half NS to make sure that they're getting some free water, okay? You guys know the criteria for DI. It's if they're peeing more than 200 to 250 an hour for 2 hours or over 500 for 1 hour, or if their sodium jumps or if their spec grav drops. In post-op DI, which I'll show you in a second, but you guys already know, you don't want to make DDAVP standing because of the triphasic response until you've given them several days to kind of declare themselves. And in patients with severe brain injury, if you're treating with DDAVP, you have to be very, very careful with standing fluids, because those are patients who are already somewhat relying on hypernatremia to prevent herniation. Unlike the post-op DI patient, if they drop their sodium very quickly, there's almost no vasogenic edema, so it doesn't matter, right? In the TBI patient with global cerebral edema, that really does matter. And so the TBI patient is very different, and it can be catastrophic if you just dose DDAVP and you don't think about your fluids. And this is just a reminder that there's a triphasic response in a lot of patients after surgery, where first they develop DI, then as the pituitary degenerates, there's actually vasopressin or ADH release, which causes them to have SIADH. And then they go back into DI, or they don't need DDAVP anymore, and they just return to kind of normal. But this is why you don't want to have standing DDAVP immediately after surgery, because when they go into SIADH and you're giving them extra DDAVP and you're telling them to drink a lot of water, those patients can drop very precipitously. And every so often you see a patient return to the ER from home with low sodium, right? Just some special considerations in severe hyperglycemia. So remember, in hyponatremia, I told you we have to correct the sodium for very high glucose, right? Same thing in hypernatremia, but because the glucose is so high, they basically are hyperosmolar, and the glucose causes a diuresis similar to what mannitol does, right? So those patients can be very volume down. And then you need to be sure to correct the hypovolemia, but as you're giving them insulin, insulin is going to drive water and glucose into the cells. So you're going to have to be very careful about your volume resuscitation. So going back to Dr. Kellner's patient who comes in looking hypovolemic, he has a sodium of 160, but he has a glucose of 1,275. And I'm going to calculate his sodium for you. The sodium becomes, the calculations become somewhat inaccurate when the sodium is very high, but with this calculation, his actual sodium is about 188, okay? That's basically like not really compatible with life. So we need to get his sodium down. We don't know how long this has been going on, but he's been at a nursing facility, so it could have been quite a long time. And then he's also extremely volume down, right? And he might be septic, and he's extremely hyperglycemic. So this guy obviously is very hypovolemic. We're going to correct the hypovolemia. So, you know, this guy received 3 liters of fluid, became progressively more hypotensive, needed a central line, started a levo drip with aggressive fluids. He got antibiotics. We calculated his free water deficit as 14.5 liters on arrival. Okay, and that's consistent with him dropping 12 kilos in 2 months. That's an insane free water deficit to have to try to fix. So we tried to calculate how fast to correct, but it was complicated by, is he seizing? He's a guy who has a seizure disorder and now has no neuro exam. How will his total body water change as he's on this high dose insulin drip? The insulin drip changes are going to, he's going to be very sensitive to insulin initially because he also has an AKI. How do we get his anion gap to close? And so he was started on half NS at 125 an hour plus free water flushes, plus all the volume he got. And so he got net in 10 liters over 24 hours. And you can see here that initially his sodium's not changing very much, but it is if you take into account his glucose, right? So we're correcting his glucose and therefore the sodium is actually changing. But this is a case where it's super complicated and hopefully you guys are not managing that at all on your own. Do people have questions about anything?
Hey, Alex, thank you. That was great. I did have one question in regards to the risk of CPM at varying levels of hyponatremia during your correction. I know that's come up in the past where, you know, we've tried to correct somebody, from 132 up to 139 or 140, who has a risk of cerebral edema. And it was, there was this discussion that there was a huge risk of CPM versus someone who was getting brought up from like 116 up to like, 125 or 128 or, corrected up. I mean, at varying levels of hyponatremia, can you talk about the risks of CPM there and correction?
So, that's a really good question. And renal oftentimes is treating those two sodiums and those two rates of correction as equivalent when they're not. So someone who comes in, recently we had a MICU overflow who came in at a sodium of 108. That person is going to be at much higher risk of CPM increasing by 10 points compared to someone who comes in at 130 and you want to get them to 140, right? Because 130 is much closer to physiologic. It depends, like I said, it depends a little bit on underlying etiology, other comorbidities, and the duration of the sodium being that low. But in general, we feel that after the patient gets to about 130, the risk of CPM is extremely low, right? Because 130 is close enough to normal that it's not that huge a deal unless the patient is a chronic cirrhotic. Obviously, there are times where we correct the patient too fast, even though it's chronic, because otherwise they will die, right? And I think it's worth having that conversation, especially with renal, when you're like, look, this patient has a lot of cerebral edema, they're herniating, they may get CPM, but they will die if we don't fix the sodium. And in cases like that, you can try to use mannitol kind of a lot more frequently to kind of tide you over so as not to fix the sodium too quickly. Like, let's say you're seeing someone who's chronically at 120. But it definitely matters where you're starting in terms of your sodium.
Great. Thank you so much.
The other thing I'm just going to
I had a question.
Go ahead.
Sorry.
No, go ahead.
You made a somewhat offensive comment earlier about the salt tabs.
I was just going to talk about that. I really want to explain why salt tabs don't work in general. So SIDH is basically, severe SIDH is basically the only time that salt tabs will work. So SIDH, again, is hanging on to too much water, right? You can, let's say, the treatment is to volume restrict them, right? So you're going to free water restrict. And let's say you free water restrict to like 250 cc's a day, and they are still hyponatremic. That is a case where if you check their urine osms are going to be so high, like 600-700, that they're never going to be able, you can't volume restrict them enough to get them to actually pee. So in that situation is the only situation in which you can use salt tabs to increase the solute, because at that point, they need extra solute in order to be able to produce urine anymore. But that is basically the only case, is if someone's pretty stable, but still hyponatremic. Usually they have, it's like a little old person who doesn't have a lot of solute intake. And so you can do salt tabs, or you can just tell them to eat a lot of salty food. But this is usually like the tea and toast person who has severe SIDH. Other than that, if you have someone who is hypervolemic, you don't want them to be increasing their salt intake, right? Like, so every CHF patient is going to be hyponatremic and you don't want them to eat salt. A hypovolemic patient, they just need volume, right? So salt's not going to fix that. And even with mild SIDH, you should just be able to volume restrict. So the only thing that salt tabs are going to do for you in SIDH is allow you to liberalize the free water a little bit. Does that make sense? Also, salt tabs taste really icky. Patients don't actually like them. A bag of chips is much more delicious. Anything else? All All right, thanks.
Okay. Thank you very much, Alex.